see the chat room. And if you have any questions or comments during the presentation, please use the chat room, or because we have little technical difficulties today, just feel free to unmute yourself at the end of the talk. That might be better because it might be difficult. All right, and without any further delay, I'm going to introduce our today's speaker. Dr. Krieger is a professor of clinical medicine in the Department of Medicine, Neurology, and Genetic Medicine, and chief of the Sleep Neurology Division in the Department of Neurology. She's a medical director of the Center for Sleep Medicine at Yale Cornell Medicine, and is also an associate attending at the New York Presbyterian Hospital and at Rockefeller University. She also is involved in many healthcare policy and management and has a master's degrees in global public health. She did her medical school from Federal University of Rio Grande in Brazil, and then her internal medicine residency at University of Chicago Hospitals, followed by critical care fellowship at Finch University, and her pulmonary medicine and sleep medicine fellowship at New York University. Over the past 25 years, she has been actively involved in providing comprehensive patient care in sleep medicine, overseeing the Center for Sleep Medicine at Yale Cornell. She's also actively involved in medical and subspecialty education and research. As a clinician scientist, Dr. Krieger is a PI in collaborative multidisciplinary research projects in various sleep medicine and has published extensively in this field. Her research is sponsored by the NIH and the National Science Foundation, and she also serves as the chair of the Mentor to Independence K99R grant review committee at the NIH. She's an active lecturer, regularly contributing to media efforts aiming at improving sleep health in the population. She's a Robert Wood Johnson Scholar and fellow of the New York Academy of Medicine, along with ACP and American Academy of Sleep Medicine. So without any further delay, I would like to hand it over to you. And thank you so much for joining us, Dr. Krieger, for the topic COMISA, Comorbid Insomnia and Sleep Apnea. And it's all yours.
Thank you so much for this kind introduction. A pleasure to be here, virtually this time, and to speak with you all about COMISA. And it's a topic that I think has been quite puzzling, for many of us, although we have seen a lot of this in the practice. It's interesting that nowadays it has become a little more of a formal kind of diagnostic modality. And I think there are several important items that I would love to discuss with you all as I, endeavor on reviewing the subject, which I have been doing for the past year at least. So feel free to also interrupt. You can save questions to the end, but if there is a burning question, do feel free to interrupt me. Do not worry about that. And hopefully we're not going to be over time. I think this is like 2:08, so I, have about 30 slides. So hopefully we can have plenty of time to discuss, because my goal is really to make this more of an interactive discussion, because as you will see, there are more questions than there are more answers than questions in the presentation in our field in general. So again, thank you so much for the invitation to be here today. I started with a picture of Central Park last weekend. So that's what you're seeing on. We had that one beautiful day in the beginning of my walk, and ended up cloudy and snowy as I was ending it. So I was happy to capture that particular special moment. So COMISA basically stands for this comorbid condition of insomnia and sleep apnea. And there are different prevalences that have been discussed in terms of sleep disorders in the population in general. And this is just, some aggregate data. This was from the National Sleep Foundation, that of course insomnia seems to be more prevalent in women than men. Insomnia overall is more prevalent than sleep apnea, although again, as you know, different populations can have different prevalence of disease. Sleep apnea per se is more prevalent in men than women. But those are really the two most common conditions that we get to see in the clinic. We haven't formalized, the evaluation of other circadian disturbances and other conditions as well, which we all get to see in our practice. But this is the bread and butter of our clinics. So the concern that we have is now we're combining two very common conditions that independently they are very challenging already for us to manage, and now in combination I think it becomes even more challenging. because what we have been seeing in the clinics is that patients need more and more attention, as time goes by. A lot of chronic care is necessary in sleep disorders. And in addition to that is what the literature is telling us, that there is an associated increase in clinical dysfunction when those are combined, and possibly worse outcomes as well. So we need to pay a little more attention to this. I just want to start back 50 years ago, which for many of you that are new to the field of sleep, if you look back 50 years ago, there was very little that we knew about sleep in a scientific manner. And in 1973, there was the first publication of what now we discuss as being COMISA, which was a description of insomnia with sleep apnea by Christian Guilleminault, where he described as Muse syndrome. And what I find very interesting about this is the fact that we take for granted that people have sleep apnea, we do a sleep study, and we diagnose and we treat them. But back then, we really did not have much knowledge or understanding about the sleep apnea perspective. So many sleep centers were evaluating people with sleep disorders, including insomnia. So this was the first description of this Muse syndrome, where sleep apnea was associated with insomnia, meaning somebody presented for a workup of insomnia was found to have sleep apnea. And those are repetitive episodes of apnea occurring during sleep. So in 1973, this was the highlight, that there was important clinical implication of patients with insomnia that may have OSA. And we find ourselves 50 years later, in the same type of situation here. So in the historical perspective, since then what happened is the fact that this was really an innovative thought back in 1973, because the sleep studies back then did not include respiratory monitoring. They include EEG monitoring. And as many of you know and lived through the moments that, there was a lot of discussions on how to best monitor respiration in the 80s and the 90s and the 2000s. So this was a period where they were doing more invasive monitoring with esophageal balloon to monitor intrathoracic pressure, even swan guns, catheters, which nowadays would be almost unthinkable for us to do that, in the sleep laboratory. And they identified mostly non-REM and central apneas, which I think is an important point. Again, this is just the beginning, but it's an important point for us to discuss. Because we often talk about obstructive apneas when we discuss COMISA, and I think central apnea needs to be part of the discussion. So after that initial case, they identified 8 more cases. 61% had central apneas, about 20% obstructive disease. And they put in a newspaper ad for chronic insomniacs, got several more patients, and with something similar that they saw, about 73% of people were snoring. And a few of them, about 15% of the insomniacs that had been snoring as well, they had sleep apnea. So unfortunately, nothing much happened since. So the field evolved, over the next several decades, over the past 50 years, into better understanding technology, advancing technology. The whole misdiagnosing has been a challenge that many of us have dealt with. Epidemiologically, the field has grown a lot, particularly with obstructive sleep apnea. And in the 1990s, there was a big discussion when, as well from the same group in Stanford, the whole upper airway resistance syndrome was discussed. And it's interesting that the description of UARS is actually different than what COMISA is or is supposed to be, because upper airway resistance patients tend to have more of a hypersomnia syndrome that is not well explained. So it's a little bit different than people with insomnia that you can't improve their sleep and later you find that they have obstructive sleep apnea. So on the timeline, this is actually a very nice chart from Alex Sweetman that shows COMISA in the literature, from the 1973 publication up to the late 2010s. And we could see that there were scattered publications until about 1999. There was 80 patients being evaluated, and they found that 30 to 40% of OSA in older adults was found in OSA adults with insomnia, because they also were snoring and they had sleepiness. 2001, about 50% of patients with insomnia were also found to have OSA. And then several other review articles discussing the epidemiology and the pathophysiology of those conditions have been looked at. In 2017 was when the name COMISA was coined by Alex Sweetman. So this is an interesting chart that you can find on a publication from Zhang looking at the prevalence of COMISA in the world. And they did a systematic review, a meta-analysis, distributing the world in the 5 WHO areas. And what they were able to find out using the limited studies that they had up to 2018, and also excluding PAP users, veterans, and trauma, which of course can change a little bit the dynamics of the data. They found that insomnia in OSA was similarly present in Europe and the Americas, on that 48-49% of patients, but less so in the Pacific Islands. And what is interesting, and here I introduce some of my take on this topic, which is the distinction between insomnia in OSA, which clinically we know that that is very frequent, and we wouldn't pathophysiologically think that, of course, if you are waking up multiple times because of respiratory abnormalities and you are not aware of the respiratory abnormalities, the manifestation could resemble insomnia, the run-of-the-mill insomnia people might have. So that's why I, in my mind, to better understand this data, I'd like to make this distinction, because I think that is different than when you find an OSA in insomnia, which is the reverse of the equation, right? People come in and they are just managing their insomnia, and you happen to do a sleep study, and now you find that they have sleep apnea. So the OSA in the insomnia population seems to have a lower prevalence than the insomnia in the OSA group. Other important findings on the insomnia in OSA that derived from that particular meta-analysis was that sleep maintenance insomnia was more frequent than early morning awakenings, which both were more frequent than sleep onset insomnia. And that, again, something that we get to see in the clinics. They did not find age as a factor that was related to the COMISA in that population, or BMI, although BMI seemed to be associated with some more severe insomnia. Severity of insomnia also was related to an early morning awakening, but there was a small association with that. Women with sleep apnea tended to have more insomnia complaints than men, and clinically, if we go back to our first slide, in prevalence, we know insomnia is more frequent in the female population. So I think different groups also have been evaluated and give a little more light into the challenges that we have in determining this condition. This was a study from the US military personnel. They found about 37% of them having COMISA. The groups at risk were mostly PTSD and people with anxiety, but they also found a high prevalence of sleep disorders, predominantly insomnia, in people with fatigue and depression. So this is the chart that really tells you the percentage of the group that met the diagnostic criteria for either insomnia, OSA, which is the middle bar, or COMISA, which is the grayish on the right side. And we could see that, again, highlighted in red, the PTSD and the anxiety groups had more COMISA, and the groups in green, which are the depression and general fatigue, tended to have more insomnia, which adds another complicating factor to this equation, which is all the overlap with mood disturbances. And that has been a challenge in our field, since the beginning, basically. So in Norway, they decided to do then a population-based study, like, let's just look into the population and see, what about COMISA in people that are out in the community. So they used a cutoff of 5 and 15 for AHI to discriminate the different levels of severity, and also used an insomnia symptoms score, but they follow the DSM-5 insomnia diagnostic criteria. They pulled from this, as a random sample in Norway, 206 patients or people and that underwent PSG. And what they found here, highlighted on this red line, is that from all participants, if you break down the severity of sleep apnea, people that have more severe apnea tend to have less insomnia again, populational-based data. It was interesting to see now in the bold area, you can see in the middle of the graph that the prevalence of sleep apnea in this population-based data in women was about 15.9, and in men was 48%, which goes back again to our initial discussion. Of course, sleep apnea is more common in men, but it's an opportunity always for us to look at populational-based data. It's very helpful to see that. So in the clinic, many risk factors potentially, how about postmenopausal women? Is age really a factor? Is obesity really a problem? Are people that are failing CPAP now, the COMISA patients, is that an easy way to identify them? How do we handle this bidirectional relationship, predominantly with mood disorders as well? The gender difference as well, and is there an inverse relationship with OSA severity? As those are being proposed as risk factors when you evaluate patients. We don't really have an answer, to be honest. This was another interesting study from our colleagues in Rio, where they were actually looking at all patients that had PSG, so there are about 12,000 patients, and they decided to look at the frequency of a positive study for OSA, broken down based on the number of insomnia complaints, and they found that people that had more insomnia complaints had a little less OSA in terms of the average prevalence in that particular group. And that was the same even with moderate or severe disease. Again, is this an inverse relationship or not necessarily? But it's just important for us to try to distinguish what are the factors actually that trigger this combination of symptoms. Arousal threshold was another big discussion, and we know that started with the upper airway resistance, looking at people try to understand the rare events. You have a mild respiratory event that wouldn't even in the beginning of the history of our field wouldn't be classified as a significant event, but people would wake up from it. So there's a few studies looking at the arousal threshold in COMISA and trying to understand, how to best evaluate that. To be honest, I don't think the jury is out, and we'll discuss some of the data. I think methodology is really critical, and it's very hard to do a really methodologically sound study in groups that are large enough and not biased. So this is one of the studies where they actually took a random group of people with either OSA only, small sample 51 and 52 with COMISA from a larger database of participants that were using indirect measurement of an arousal threshold using a calculation from the AHI, low saturation, and hypopneas during a type 3 study. Again, I think methodology is critical for us to really answer the questions that we have in our field. It's an interesting study, but I don't think, as they did not find significant differences with the arousal threshold, we all know a type 3 study and an algorithm with an important question, I think is very difficult for me to take this as a face value, to be honest. I think it's a helpful study, but it doesn't really fully answer the question, sorry. The definition of insomnia in this group was a score over 15, and OSA was defined over 15 events per hour. They found as well that OSA only group had more males than the COMISA group, which seems to be a trend, but we're concerned again about the methodology used. So another study doing something similar, looking at COMISA versus OSA only matched subjects. So 72 in each group was looking now at cortical arousal types, looking at respiratory versus spontaneous arousals. And what I found very interesting about this is that they broke down into the duration of the arousal. This is a short arousal, 3 to 6 seconds, 6 to 10 seconds, or a longer arousal. And they evaluated the beat-to-beat heart rate from the onset of the arousal up to 30 beats later, and evaluated the peak of that heart rate response and how long was the recovery phase. And the chart now shows the 3 different types of arousal duration. So the majority of people had short arousals, less than 6 seconds, then about a third of the sample between 6 and 10 seconds, and about 15 or less, 10 to 15 seconds. And you can see that the OSA, which is the field dots on the chart, really lines up with the COMISA for the short arousals. But as the arousals get longer, you could see that there is now a distance that you tend to have a higher peak heart rate response in a longer recovery phase for the Comiza patients. Again, this is not indicating, what causes that, but it's just telling us that is physiologically that is a difference in the response. We still don't know what the triggers are, but this is a very interesting physiological study. So their definitions were as well the insomnia score over 15 and OSA over 15 events per hour, which I always like for us to pay attention to when we read the literature, because if we don't think that very severe apnea is a problem, if we want to look at more mild apnea in patients with Comiza, I think some of those studies with an AHI of 15 as a cutoff, we lose the ability to determine what happens with people with more mild disease. But they did not have any significance in the number of spontaneous arousals. The OSA, of course, had more cortical arousals because of the respiratory events, and Comiza had just longer arousals. And as we saw, they had the longer heart rate peak in recovery. So I think this was also very interesting. Of course, some drawbacks in the methodology. A lot of the scoring system was done automatically, but that might be some intrinsic errors on the detection. However, it was the same scoring for every subject, so it will be just an internal bias that you probably would not be related to the findings that we saw in here. There's also a lot of discussion about OSA endotypes, and how does Comiza relate to that, I think is a very interesting question for us. A group, again, of small sample, 34 patients with Comiza and 34 OSA only, matched for age, sex, and BMI, were evaluated for 4 endotypes during non-REM sleep events. So looking at airway collapsibility, muscle compensation, loop gain, and arousal threshold. And they define insomnia by DSM-5 and OSA as AHI over or equal to 10. So this chart now is just showing you, again, in red, we have the Comiza, and in blue, you have the OSA matched controls, not controls, but OSA matched group. And you could see that the airway collapsibility seems to be different between groups, not as much of a difference with the muscle compensation or perhaps the loop gain. And perhaps the arousal threshold was actually lower on patients with Comiza, and that was statistically significant. Although there's a big overlap, we can see on the arousal threshold as well. I think the part that we have the least overlap was really on the airway collapsibility. So it looks like the true mechanism of sleep apnea, of obstructive sleep apnea, again, on those patients might be different because the airway is not as collapsible. And it goes back to the question, are we including only obstructive events or not? It would be ideal if we were able to get esophageal balloon monitoring pressure on those patients, really try to understand arousal and respiratory physiology a little bit better. But it seems, based on this data, that is much more direct than the previous data. We're using only home studies, that the airway is not as collapsible. So the mechanism for airway obstruction is probably different. And they're just waking up more easily because they have a lower arousal threshold. Another interesting study was looking at the genetics of Comiza, trying to understand, are just some genetic overlap between the chromosomes and what we find in patients that have OSA and insomnia. So Susan Redline's group did a study looking at over 50,000 patients of European ancestry, and they were not able to find overlap. So they had very minimal genetic coding that was shared. So we see in green here, we see the chromosome 8. So a lot of presence with changes in the sleep apnea cohort, but not as much. And if you can see, the part that was affected on the chromosome was actually different in insomnia as well, on chromosome 8. And on the chromosome 1 for sleep apnea as well, and insomnia, so no real overlap. So I think that is, again, mechanistically makes sense, clinically makes sense, that those are not diseases that are, inherited together, let's say. They could be independently present, and that makes sense from what we see clinically. So the importance of COMISA, I think, well, I just want to have a brief pause, for us to understand that this is not just an academic discussion. I think it is an important discussion because patients that have the combination of diagnoses have a detrimental effect in neurocognitive function. They are sleepier, they have more mood disturbances, they have a higher risk for physical and mental health problems. They, of course, as we see, the healthcare utilization goes up the roof. Some of those people, as I'm sure you see in your clinics, they need almost weekly visits, which is nearly impossible for us to maintain. If they are younger, their work performance is really inadequate. They are absent from work. So there are many issues in the public health realm that we need to focus on. They also have worse quality of life and quality of sleep, and as you spoke, neurocognition. Another interesting study that was done on those patients at Penn was to actually look at the daytime functioning. So this is, again, a populational-based study, which, again, I love those because they are really less biased into the sample of patients that come in. So they looked at the daytime functioning adults over age 65, and they selected 99 that met the diagnostic criteria for insomnia and 100 that didn't, excluding depression, dementia. Everybody had a PSG over 2 nights and followed by a PVT and an MSLT. And OSA was diagnosed as an AGI over 5 with a 3% desaturation. So they found overall as a prevalence, just as a statement from the group, that they found a 29% of OSA in the population of insomnia in those 99 patients and 38% of OSA in the controls. So now we see a bit of an inverse relationship, right, as we saw on that population study from Norway as well. What was fascinating is that on that performance test, so this is actually now looking at FOSQ, the global scores on the population. So we're comparing on the left the sleep disorder breathing, insomniacs in the middle, and COMISA to the right. And if we look, I added color, I think just makes it easier for us to see how in green, the activity level scores were lower in insomnia and further low in COMISA. Intimacy in yellow was actually lower in sleep disorder breathing compared to insomnia, but significantly low in COMISA patients. Vigilance was also similarly to activity level, was lower in insomnia and even lower in COMISA. And of course, then the global score followed the trend of most of the variables that was linearly worse in COMISA patients as compared to insomnia, which was lower than sleep disorder breathing. So this was actually another interesting aspect. There hasn't been much research on that particular aspect of the intimacy, but you would imagine if, of course, if they are snoring or not breathing well at night, waking up because of that, in addition, having insomnia is probably affecting, their intimacy level. Another part of the study was now looking at MSLTs and PVTs. So that was also, again, fascinating because you have then more perspective on this populational-based study. And the MSLT scores are actually very similar. So we can see the first group is no insomnia or sleep disorder breathing. The second group is sleep disorder breathing, then insomnia, and finally COMISA. So they are all MSLT scores on that 13 to 14 minute average. Now the median reaction time on the PVT, we could see that it was longer on the COMISA, and that was statistically significant. So when we talk again about the neurocognitive function, we can see they have longer reaction times. So I think that was also a very interesting finding. The lapses were not statistically significant. It's sometimes hard to achieve clinically significant because with lap 1, 3, 4, 5 lapses, the difference between 3 and 4 sometimes is very hard for us to really measure statistically. So other studies then focus on the neurocognitive realm to better understand, in tasks, like how do people perform? And this was a very interesting study, for many reasons that came out not too long ago, I think it was last summer, that looked at this additive detrimental effect in neurocognitive function. And on the left, we have the neurocognitive dysfunction that is often seen in insomnia, in memory, problem solving, attention vigilance, working memory. And on the right, on the far right, the OSA dysfunction in executive function, visual memory, also attention vigilance, visuospatial and construction ability, psychomotor speed, verbal memory, all the things that our patients with OSA complain with. And now the COMISA group, interesting enough, has a combination of both. So they don't tend to have all of them based on this particular study, but they acquire some of the neurocognitive impairments from each of those diagnoses. So I think that is also very telling because, again, it tells us how they compile. They didn't acquire all categories, which was interesting, but some of the categories were more important than others. This is the same study, so that's how they acquired the data. It was a group of 45 people with COMISA that was part of it's an ancillary study to a larger trial that they pulled out all the patients with COMISA, and they were randomized for different treatment approaches. So that's what allowed us to evaluate, or allow the researchers to evaluate the neurocognitive function. Those patients had also a more strict inclusion criteria. So patients on medications, patients had severe OSA were not included, patients with PLMs or restless legs were not included, which might have, led to some of the changes. If I go back in here, psychomotor speed, verbal memory, visual memory, executive function. If all those COMISA patients had severe OSA, I'm sure that would have carried over because we do see that in the clinical practice, right? But it wasn't evaluated because the severe OSAs were removed from the study or not included. So what this study was actually doing, and there's another part of this study that I think has been very helpful for us, is the fact that it randomized treatment approaches. People had that first baseline PSG followed by the neurocognitive assessment, and they were randomized into getting CBTI before getting a PAP titration, and that was that group 1. And then the 2 other groups eventually had the CPAP titration, and group 2 added post-titration CBTI, and the group 3 just had PAP titration. The total numbers in each group was 10, 15, and 14. And what was very interesting for us to see is that as they checked neurocognitive assessment post-CPAP titration, meaning immediately post-PAP titration, and then a month after treatment, what they identify is that the neurocognitive function was improved with CPAP, which again confirms what we do see clinically. However, it deteriorated on that first group that only had CBTI initially. And could be for many reasons, but it could be because the CBTI, the CBT4 insomnia includes sleep restriction as well, and that may be a factor, might not be the only factor. But we see here on the right side, then a rough, comparison on all of those neurocognitive functional assessments. And this is a chart that looks at the probability of superiority of treatment over the baseline test, so over that time 0. And we could see that CPAP seems to be, pretty superior on that 80 to almost 100% range on almost every task, and CBTI to be probably inferior, at least in working memory and psychomotor speed, questionable in executive function, but maybe okay for attention, vigilance, and verbal memory. So this was, in a sense, that another important study just to highlight that first line that I put in red in here, that we must treat OSA. I think once you find a mechanical problem with the airway, it has to be treated. Not that it is easy. The more patients you see, the more challenging almost it becomes. But it's something that we have to always keep in mind. We can't ignore that and only focus on the insomnia management for patients. There's also some interesting data look at COMISA in patients with hypoglossal nerve stimulation. They have determined that in this particular study that the Inspire, in the sense, was the stimulator they were using. The usage based on insomnia complaints was lower for people that had insomnia issues, and they had more pauses at night. It's interesting because they don't have here a comparison to people that had no insomnia, no reports of insomnia issues. I think that would have been very helpful. And they also noticed that based on the diagnosis, all patients, now patients with OSA alone or COMISA, the usage was actually lower on patients that had COMISA versus OSA alone. And they had a lot more pauses at night. So that more or less answers that first question. You know, people don't have any insomnia issues. They are falling into this OSA alone category. So that's another important factor for us to consider when people fail. And of course, there's data on CPAP as well, when people have failed to tolerate CPAP or AutoPAP, and having insomnia is really a big factor driving that. And we need to focus on how to improve their insomnia, not necessarily in changing treatment right away, but that has to be a more comprehensive evaluation. Now, to highlight again the importance of COMISA, I think this is some data looking at, it's very recent data that was just published, looking by Susan Redline's group, looking at the incidence of diabetes in men. And this was osteoporotic fracture studies in men, about 2,300 subjects. And what they were looking at is just different subgroups and a different definition of obstructive sleep apnea as well. So they call this an SBII, which is the product of the duration of each respiratory event, both apnea and hypopnea, and the accompanying desaturation area, which when we speak about, you know, the repercussion of the event is probably a better way to evaluate sleep apnea. And they were able to find out when you have the combination of COMISA with a fully adjusted model, with using this particular index, there is a higher incidence of diabetes in those men. Again, this was only man studies. And when you use the crude AHI or even the fully adjusted AHI, the data is a little bit different. The crude without adjusting, it's also significantly different. But however, when you adjust and you use the basic AHI on the model, you know, you lose the statistical significance because now it crosses 1. But I think it's just another important aspect for us to remember how important it is. So just as a summary here, so the combination using this particular index for sleep disorder breathing had a higher risk of incident diabetes, a hazard ratio of 1.82. And yeah, so I think that is another important thing for us to just keep in mind. And yet another study that just came out last year with, and Carl Yagi and your team were involved, which I think was very important, is the incidence of atrial fibrillation in insomnia. Even if this is not a COMISA study, I think it's important because there's a lot that we don't really know in insomnia and in endotypes of insomnia. I think it's just something that has not been well evaluated. And who are the people at risk? You know, there's definitely, the study was showing that having insomnia increased the overall likelihood of atrial fibrillation, you know, many years down the road. So this is a study that at year 9, 10, 11, there was really no significant difference, but the difference starts, you know, to develop at year 12, and on by year 15, there was a significant change. It was, again, it's a low incidence, but it's still a significant difference. So it's important for us to keep in mind when we manage patients. And many of us being in the field now, you know, a few decades, we do see people, you know, later in life developing problems. And at the same time, we see many people getting through without any issues, right? I'm sure many of us have people in their 80s, 90s, even over 100 with insomnia without having any other repercussions. So I think we still need to better understand insomnia, which will help us then help the definition of COMISA, like which groups should be even included in the COMISA. So in summary, I think a couple of things that I want us to pay attention to when we read this literature is that, in my perspective, again, this is my personal opinion, insomnia in OSA should be treated differently than OSA in insomnia. We do need clear definitions for disease, and I think that is really something very important. So basically what I put on this chart is that green is what more or less of the prevalence in the general population for insomnia, and then we have the prevalence of OSA in the general population. Now in yellow is the prevalence of insomnia in OSA, and then we have in orange the prevalence of OSA in insomnia. So there's a lot more overlap with the general population with the OSA in insomnia and less overlap with the insomnia in OSA. So that is to say that perhaps insomnia in OSA is something that is much more common than in the general population, and it's something that we need to pay more attention to. And that OSA in insomnia is probably has a similar prevalence perhaps with the general population. So people with insomnia should be screened as a general population would be, but OSA patients need to be more carefully screened for insomnia because they do have more insomnia complaints. The complex relationship, so nothing is ever simple in our field. We have this significant morbidity, this overwhelming need for care that we need to pay attention to. Again, clinical and public health implications. And we do need further research to help identify the groups at risk. And a couple more important items I think we need to discuss is, as I mentioned all along, definition is a challenge. I think I'm always pro methodology, and that's why it's sometimes very hard when we have been in a field that definitions have changed frequently. We need to know the criteria for insomnia, at least for research, so we can better understand. We need to figure out how we're going to define and, hopefully use that across the board for consistency. We need to understand the different types of insomnia. Does it really matter? Criteria for sleep apnea is also critically important in all of this. What are we using? Are we making criteria to fit, the results, or are we really trying to better understand how to determine what is relevant in terms of sleep apnea? We need to know from publications, is that a direct or indirect airflow monitoring? Are we including central events, or is this mostly central versus obstructive? What do we do with RAM OSA? What do we do with position OSA? How do they fit into this equation and the methodology and all the studies that are being done, that have been done, and that will be planned in the future? We also need to look at confounders, mood disorders, the effects of therapy. Most people by now are treated or been treating their conditions one way or another. And we need to understand the different populations that are being studied as well, as particularly in women, the postmenopausal changes, with that increase, we see a lot of RAM-related OSA in women. We see a lot of AFib in that population. Can we do studies to really try to identify and tease apart, the risk factors more soundly? And finally, just to add to the complexity of this, is just the challenge that we have in treatment. This is now just focusing mostly on the OSA, and I took this slide from Thomas' publication from September last year. I thought it was a very interesting way when they looked into those 4 endotypes of OSA, and that's the study where we show the difference in the arousal threshold. So that has been something that has always been discussed. And what is fascinating, I just highlighted here in this blue bubble, to treat the respiratory arousals. It's the treatment that we have been using for insomnia, right? All along, like if we can manage insomnia, are we able to improve respiratory function as well? There's a big push in the field, and not only in the field, in medicine and social media, against sleep medications. And I think we need to better understand the effects of poor sleep versus the effects of medication, improving their sleep, and what types of medications are safe or not. So I think there's so many layers of complexity. We always try to do the best we can for our patients, given all the data that we have in terms of research and knowledge. And what is not included in this slide is what we have to always consider in clinical practice, cognitive behavioral therapy, as well, the insomnia component. Education support for patients is very important, and access to care and close follow-up. And that, again, is our day-to-day challenge, in how to provide the best care to our patients in this enormous amount of people that really need support. We live in areas with millions and millions of people. We don't have enough specialists. Many doctors don't have the time that they need to manage their patients, not necessarily only sleep doctors, but every other doctor in primary care. So I think this is a huge public health challenge, and I think our field has to do the best it can to identify the best methodology so we can come up with the best data and the best guidance for other people to be able to help us manage patients. And I'll leave you with a picture from that same walk at Central Park, where what I love about this is, again, you see the reality, let's say, above the water, but you see the reflection. And I think we need to distinguish, what is the reflection, what is the reality, and try, how do we put the whole picture in perspective and try to figure out the best management for our patients. So thank you so much again for inviting me. Really a pleasure to be here today.
Thank you so much, Dr. Krieger. Thank you so much for the excellent deep dive into this, one of the most challenging and yet common topic, that we see on our day-to-day clinic patients. I had a quick question, with this COMISA, with our majority of patients being sleep apnea and insomnia patients, trials have shown combining CPAP and CBTI is effective. More so, but then with this, we don't have easy access to CBTI and less providers doing CBTI. What about the pharmacologic treatment? And if we were to do it, how long? Any thoughts on that?
Yeah, I think that is such an important point. I think with access is huge. I think we have to figure out how to expand access to non-pharmacological approaches. I think it's just something that I do a lot for our patients. It takes so much time. I've been seeing patients on Saturdays now. I don't even know what to do. Like today, I'm seeing people in the evenings because I think we have to figure out how to have a comprehensive evaluation to avoid medications if possible, right? But I don't think medications are evil. I think medications need to be part, as they are in every other discipline. Now we're talking all the weight loss medications that we know very little about. They work really well. It's like when Ambien first came out, right? Zolpidem is the best thing in the planet. Everybody wanted to be on Zolpidem. So I think we have to, understand that there are diseases and conditions that need to be treated pharmacologically. So I think we have to embrace that. And I think I've been pushing, that a little bit hard in our own group and our own researchers that do a lot of neurocognitive research, because they always feel that medications, oh, this is their sleep medications, this is their sleep apnea. This is like, wait a minute, right? It's not only the sleep, we can't just easily, brush off, a symptom because nobody knows what it is and just blame sleep. So I think we have to embrace this very seriously as, a series of important conditions that we have, an armamentarium of behavioral and pharmacological and device treatments, and we do our best to offer them to patients. But we need help. We need virtual access to care. We need the standardized, improving modules that can then be reproduced and deployed even in more remote areas for patients. So it's a complex, answer to your question. But I think we have to use the tools and also personalized care, which then adds a final layer to this onion. Like every person is a little bit different. And how do you personalize that to a given patient?
Right. This is a very challenging one. Thank you. We have Dr. Clara Yagi here who says, Anna, fantastic overview. Can you speak to any studies examining CBTI in this population? I believe there is evidence that it may reduce AHI.
Yes, so improved behavior and improving sleep can decrease, if you decrease the arousals, you could actually attenuate some respiratory events. And I think that's something very important because remember when we look at the studies, like a lot of them have different AHI categories for inclusion. If you include people with lower AHIs, you might be able to actually get them to go into a normal index, right? By addressing their insomnia and behavioral issues. Some of them may also have central events like anxiety, and they just blow out a lot of CO2 during the day, and they may have some instability in breathing that gets captured on that AHI. You improve their sleep by CBT or medications, and their AHI normalizes. So absolutely, I think that's a very important aspect for us, because that's another issue that our field suffers with, is this concept that the industry predominantly, the insurance companies has brought on, that is, if you have a sleep problem, it means sleep apnea. If you have sleep apnea, it means CPAP. And we have to take a step back, because not every sleep apnea should be treated with CPAP. And that's a very interesting example, mild sleep apnea treated with behavioral changes. And again, across the board, weight management, right? That's another aspect we didn't even touch. Weight, how that, really affects patients. Yeah. Thank you, Clara. So good seeing you.
Thank you so much, Anna. Lovely seeing you.
I don't have any.
I think Brian has his hand up.
Oh, okay. I can't see. Brian, do you have any questions? Do you want to unmute yourself and just ask the question?
Oh, I'm sorry. I didn't mean to have the hand up. I'm sorry.
No problem. How are you, Brian?
Good. How are you? Thank you for your talk.
No, thank you guys for inviting me. This is, again, it's complex. So I wanted, and I want to hear also from you guys any ideas that you all have. We're trying to develop more setup of educational series, virtual clinics. We're trying to go like an extra mile to see what can we do almost even before patients come to us to attenuate the need, because it just is unbearable. It doesn't matter how many people you add into the staff, like the need is always,
We feel your
impossible.
pain, Anna. I think this is a hugely important topic, and right to focus in on from sort of a research standpoint. I think what's interesting to me about this domain too is particularly some of the sex differences. Christine Wan in our group has some interesting data. I think it's from one of the, I forget which cohort. I think it was MESA or one of the large cardiovascular cohorts where we did sleep studies, that women have on average, a lower arousal threshold than men, and that there may be some teleologic explanations for that.
Right.
And oh, by the way, they tend to have more insomnia associated with their sleep apnea. Women also have higher rates of adverse cardiovascular health outcomes related to sleep disorder breathing. And so, is there, I think this is a really understudied population of patients, and coming up with combination therapies of PAP and sedative hypnotic perhaps might be a path forward in better treating some of these folks. And oh, by the way, about 50% of our patients don't adhere to CPAP, and this is likely a major contributor to that, that the coexistence.
Right. Oh, absolutely. Yeah, and we're seeing also, in treatment failures with all kinds of things, right? Mandibular advancement devices has a life short span. Usually people tolerate for a number of years and then they fail. I'm seeing a lot of people post hypoglossal nerve stimulator, people that come from the community that were implanted and the disease did not budge at all.
We have that same experience. Andrei Zenchuk runs our Inspire program, and we're just not seeing the same results, I think, that were observed in the STAR trial. But it's helping some patients. But
yeah, and it's interesting. We have some people that feel better, but I just saw a patient, I feel terrible. I don't know who implanted him, but like had an AGI of 90, and now his AGI is 100. Right? And just saying, oh my God, and he's been
oh my God,
4 years.
yeah.
So, and I see Francoise, thank you. Hi, Francoise, mentioning imaging studies. Yes, I think, that's another thing, I've been talking a lot with our neuroimaging group. I think we need to have, particularly now that we have better technology for different PETs and MRIs, I think we really need to look at neuronal function. But again, it's expensive, and you need to, be funded to do those types of studies. So sliding in, this curiosity without having a formal research study planned is very difficult. I'm trying to see if our group, they are so well funded for brain imaging, but they have been focusing on just, Alzheimer's and other conditions. But it's just something I think we need to know better. There's a lot of opportunity. Neuroscience is amazing, and I think it's an amazing field. We just need to have, the right setup for research and development, because we're just scratching the surface in here.
Yeah, wonderful talk, Anna. Nice to see you too. And that was my question in the chat. Is actually I was wondering if we have some imaging studies among the COMISA patient as opposed to OSA versus insomnia alone patient.
Yeah, I'll look into that, because I'm not aware, but I'll definitely look into that, because again, it's the whole COMISA definition, right, is something new, but we definitely have lots of imaging in insomnia and imaging in OSA. But I'm going to look and see, what we have in terms of combined data. I think that's an important question.
Yeah. Thank you. It was excellent. Thank you, Anna.
My pleasure.
And actually, hello from France, actually, Lana.
Oh, wonderful. Oh, yeah, I'll send you a text later. Yeah.
Bye.
We might have one more question here from Dr. Stuart Mann. Does the presence of significant sleep onset insomnia and OSA indicate COMISA rather than sleep apnea with insomnia?
Yeah, that's interesting, because sleep apnea with insomnia typically seems to be more of that middle of the night, so that is sleep maintenance insomnia. As we always know, the early morning awakening. It seems to be more mood disturbance or depression. So I think a sleep onset insomnia might be more of the true comesia, which is the insomnia related with low arousal triggering respiratory events. But we do need, again, to really create clear definitions and cohorts of those patients so we can actually study. And that's why I decided to break it down, in the comesia world from insomnia and sleep apnea and OSA into insomnia, because if you only focus on the OSA, we know that CPAP is going to help them. We don't really know much about the insomniacs and all the different endotypes and manifestations of insomnia. So I think that's a very important question, because if that is an important screening, if people that present with sleep maintenance insomnia, let's say, should always get an OSA screening test, should they? Sleep maintenance insomnia, should we just treat the insomnia and then do an OSA or an HST or an OSA screening? I think we do need to have a better understanding on how to manage those patients so we can have a more definite answer. We'll never be perfect because there are too many variables, but I think if we have a rough guideline on how to proceed, I think will be very, very helpful. Thank you for the question.
Great. That's 3 p.m. Perfect. Right on time. And sorry about the technical difficulties, but so much. This was a fantastic talk. Really difficult, but you did an excellent job. Thank you so much again for accepting it. And thank you so much for joining in. See you guys next week. Bye-bye.
Thank you. Nice seeing you guys. Bye.